Yes, yes, yes.
Thank you,
Please.
sir. Thank you, sir.
India is a land of youth, a land of energy, vitality, and ambition. However, there's an increase in the prevalence of lifestyle diseases, that is, diabetes and hypertension. Risk factors responsible for these conditions are stress, sedentary lifestyle, obesity, smoking, and excess alcohol consumption. These lifestyle conditions are also affecting their vitality and energy, and in turn leading to one prominently occurring condition of erectile dysfunction. 52% of Indian males aged 40 to 70 years are suffering from ED, leading to decrease in their confidence level. Healthy sexual life helps in maintaining the feeling of youth and overall well-being in sexual disorder like ED. Zydus Fortisa, a division of Zydus Healthcare Limited, presents Men's Sexual Health Portfolio, which comprises of Benegra, Zydalis, You Desire, Sustanon. Benegra is the number one prescribed brand of sildenafil with half-life of 4 hours, duration of action up to 8 hours. Benegra can be recommended for moderate to severe ED patient, long-standing diabetes patient, as efficacy is independent of age, duration of ED or diabetes. Zydalis is a brand of tadalafil that comes as mouth-dissolving mint-flavored tablet. Zydalis has longer duration of action up to 36 hours with no dietary restrictions. Recommended for the treatment of younger 40 plus mild to moderate ED patients. Provides spontaneity and better patient compliance. Sustanon is a brand of testosterone used in the management of ED with hypogonadism. Sustanon shows considerable increase in duration and maximum level of penile rigidity. Improved libido in hypogonadal men. You Desire is the brand of Udenafil, which gives assurance of efficacy and safety. Help your ED patients to feel youthful and maintain overall well-being with the benefits of Benegra, Zydalis, Sustanon, and You Desire.
Good evening, everyone. My name is Dr. Aishwarya, and I welcome you all for today's sexual health webinar. It gives me absolute immense pleasure to welcome both our national and international faculty for today's webinar. The moderator for today's webinar is my favorite sexologist I have ever known, Dr. Deepak Jumani, sir. I request Deepak, sir, to take over the session. Thank you very much.
Thank you, Aishwarya, for that wonderful introduction. The most important thing which we understand, resulting in conflicts between a couple is the lack of communication and lack of transparency. If we take care of these two things, many a times most of the conflicts resolve. Many of the times we see couples don't come together. Husband comes or wife comes and shares her own woes. But what is of great advantage is when you call the couple together, it makes a lot of difference. There cannot be any shying away or any lying business, and you can really know what is the real fact of what is the problem between the two issues. The purpose of keeping this webinar is to enlighten we physicians about the art of couple sex therapy and the importance and what are the core concepts of things. And this is to be dealt by none other than Dr. Mary McCarthy, who is the pioneer in issuing, in explaining so many things about couple sex therapy. He is a professor of psychology and sex therapist from the American University. He is a diplomat, American board certified professional psychologist. He's a diplomat in sex therapy by ASEC. He's got over 20 books. He's written hundreds of chapters in several textbooks. He's conducted various workshops, more than 7 in India, in Mumbai, in China, in Chennai, and Hyderabad. And his recent book, Finding Your Sexual Voice, Celebrating Female Sexuality, is an amazing, awesome book which is ever written. And he's going to enlighten us today on what is couple sex therapy. We also have with us our Vice Chancellor of Maharashtra University of Health Sciences, Dr. Dilip Maheshkar, who is a pulmonologist of highest repute. He's a master in treating tuberculosis. He was the former dean of Shankar Rao Chavan Government Medical College. At the moment, he is the vice chancellor of the Maharashtra University of Medical Science. A very proactive, very confident, very down-to-earth practical man. He was instrumental in starting fellowship in clinical sexology at the university levels, and we have 4 students of intake in that. We also have my dearest Dr. Laparosurgeon of India, Dr. Jayalal, who is now the national president of the Indian Medical Association. He is professionally a amazing surgeon. The finesse, the precision, the amazing way he does his surgery is a feast to see him operating. He is from Trinovelli Medical College. He's also the chair of UNESCO's Bioethics Committee. One good thing which touched me when I read about him, that he's a son of a staff nurse, and with all the hard work and all the sincerity and all the commitment, he has now risen to the level of being one of the finest laparosurgeons of our country. He's also done his MBA from Canada, and he's also done PhD in many subjects, and amazing surgeon. And I really, from my bottom of my heart, thank him for gracing this occasion. He has a busy schedule. He must have attended, I think, 6 to 8 webinars today. Thank you, sir, for coming. We also have Dr. Narayan Reddy, who is the chairman emeritus of Council of Sex Education and Parenthood International. He is also the president of Asia Oceanic Federation of Sexology, my mentor, my guru, and we all look at him with regard and with respect, and we always learn from him. We have Dr. Bala Subramaniam, who is a former IMA president of Tamil Nadu State. He's at the moment chairman of Indian Medical Association's Initiative for Sexual Health. So with this galaxy of people around, of stalwarts in this webinar, I would now request my mentor, my teacher, Dr. Dilip Maheshkar, to say a few words about this webinar. Over to you, Dr. Dilip Maheshkar, sir.
Namaskar. Good evening, sir.
Good evening, sir.
Proud pleasure, my proud privilege to be here on this occasion. Today's respected all the dignitaries, Dr. Jairal, National IMA President, Dr. Barry, our esteemed guest from United States, Dr. Narayan Reddy, Dr. M. Balsubramaniam, all members of IMA across the India. It is a great honor to be amidst the such gathering of sex experts across the India and abroad. I believe that no relation is of all sunshine, but two people can share one umbrella and survive the heat of the storm and rain, etc. I also believe that behind every complaint from one partner, there is a deep personal longing. When it comes to better half, don't criticize your wife judgment. Look whom she has married to. Feminism needs to be respected and trusted and admired. If you look at the words man inside a woman, male is inside a female, lad is inside a lady, and Adam is inside a madam. He is inside she, so we are both halves of humanity. I'm very happy that the webinar is organized to understand the issues of couple and how to amicably and empathetically resolve the interpersonal conflicts and the bridge the gaps between the two loving couples. I'm very happy to understand that Dr. Barry McCarthy, a renowned psychologist of highest repute and author of several books, is sharing his wisdom on couple of sex therapy. And I'm sure that this webinar will expand and the scope of wisdom to one and all. I am proud that I could share the dais with him today, though it is virtually also. I also congratulate Professor Dr. Deepak Jamani, who is my friend, who is our colleague, for arranging this wonderful, most useful and most needed seminar and help couples live a good quality of life. Thank you very much. Jai Hind.
Thank you, sir, for those wonderful words. They were all inspiring. Now, may I request my best teacher, Dr. J.A. Jayalal, a national IMA president, to say a few words and give us some pearls of wisdom. Over to you, Dr. Jayalal, sir.
Thank you very much, sir. And beloved and respected Vice Chancellor, Dr. Dilip Mashkekar, the distinguished faculty from abroad with McCarthy, very dynamic, the most sought after person in the country, Deepak Jumani, and very expertise, the sexual medicine experts from Tamil Nadu who enjoys a great reputation in Tamil Nadu, both Dr. Narayan Reddy and Dr. Balasubramaniam, and the other distinguished faculties. I'm extremely happy to be here at this moment and represent as an Indian Medical Association leader to be with you all. Indian Medical Association is an organization which, though it caters to the needs of 3.5 lakhs doctors, and we are more concerned about the general practitioners and the average level, middle level practitioners of our country, where they need always come across, though they have a speciality of their own, but they come across a lot of kind of people with this problem of sexual dysfunction and sexual issues which they face, whether it is a gynecologist, whether it is a pediatrician, whether it is a surgeon, and where when they consider them as a family doctor, always they come and share their family medicine problem, their problem with the sexual medicine. But that is one area which always prompted Indian Medical Association to take up this field and do adequate training for our feel is in India, the most of the time the sexual therapy or sexual issues are discussed not with the qualified people but with the quackery people. And many quacks and many people from a different other system, they always take up, they always give a lot of hypocritical confidence to the people, and they do all kind of mixopathy, and that results in a great disheartening among the person as a whole and an individual. The concept of counseling, the concept of bringing together the couples and discussing with an open mind and expressing the transparency are lacking absolutely when a quack or a mixopath person is treating these people. Their intention is something different, and they always say 1 month you take this medicine, everything will be settled. So that kind of assurance is happening place. I'm so happy Deepak Jumani and the distinguished faculties of our sexual medicine people are bringing out this concept of bringing together the couple and making them understand that the issue which they are facing and enabling them to express their problem transparently and understanding and empowering them to understand what is exactly the problem they have, and finding a solution for that. It is a right step you have taken in the right way. So I'm so happy as an medical association. We would like to carry forward this vision forward, because this is absolutely needed on that today. Unless our own medical fraternity, irrespective of our specialty, even I am a surgeon and I must understand the basic things of this, and I must understand how best I will be able to tackle this needs, and then only that it will be able to go forward and do a great job. We know for sure the way in which the distinguished leaders of Dr. Jumani and other people as uh, they were sorting it out. I must say they were traveling across the country from north to east and south, and giving so much of lectures, so much of things to create awareness among the public and awareness among the medical fraternity. He is doing a lot of job. So I at this occasion I would like to congratulate and compliment the efforts of both Deepak Jumani, Balasubramaniam, Narayan Reddy sir, and all these people. You are a real asset for this. And when the person has a hernia, he comes to me for surgery, and that is a easy job for me. But when the patient has a problem with an erectile dysfunction, and it is not a day which is going to be end with a just one day treatment, you need to have a continuous hand upholding the person, and hand holding and empowering the person and understand the issue. Carry on. It is a big job that you people are doing an extremely well. So I compliment you. So my appeal to you, Deepak Jumani sir, and the including our learned colleague McCarthy sir, that you must help us to bring this as a structured training program. Not trying to produce a specialist of that cadre, but it is going to be applicable for irrespective of the speciality. Everyone should understand something which is based on this counseling of the couple, and how do we be able to bring them down. And I'll be so happy if Dilip Masekar sir, as a vice chancellor of university, also gives some credential to this courses which is being carried out, because unfortunately MCA is not recognizing this as a specialty, special course, structured course. But at least an accreditation and affiliation, if that universities or some kind of recognition, if these courses can be get, it will have a widespread practical implication will be coming. Whatever help you need from the largest professional body, Indian Medical Association, we are ready to extend to that. We always believe that this is going to be of a great help for personally for our individual and professionally for our organization and association. So I thank and compliment the efforts of you once again, and looking forward to have a very useful treatment modality or the counseling modality which is going to be propagated to the medical fraternity across the country. So I thank once again Professor McCarthy for I heard about you a lot. I was told about your great contribution to this field. So we are looking forward to hear from you, and looking forward to have your service also for our Indian country. Thank you very much for participating. Thanks a lot for this golden opportunity, sir. Thank you very much.
Thank you very much, Dr. Jailal, for your deepest understanding of what our feelings are. We all are, we all need some recognition from the Medical Council of India, and IMA can do that. We should have at least some DNB or MD in sexology. We are all born out of sex. We have issues about sex. They are so rampant. They are so much prevalent across the country, not only here, but everywhere across the globe. A specialty or some accreditation, which you rightly said, and through your good offices, if you could make it, it will be a greatest contribution to this field. Thank you very much, sir.
Before I go, I just want to request Deepak sir, because we had a lot of good relationship we maintained with the national board. Now they have a lot of diploma courses. It is been on the anvil. One of the diploma course, now we have talked with them, it is on the pipeline, is diploma in family physician course. Similarly, if you can bring out a structure for diploma in sexual medicine course, and that can be definitely submitted to the national board, and Indian Medical Association will carry forward that to some logical conclusion.
Sure, sir. We'll do that as soon as possible. Thank you very much for understanding. Now, without much ado, let me request my most favorite teacher from United States, Dr. Barry McCarthy from whom I have learned a lot when he came to India for a workshop. Over to you, sir, for your talk on couple therapy for sexual dysfunctions. Over to you, sir.
Okay. Well, thank you very much. Again, who I am is I'm a psychologist, sex therapist, and couple therapist. I've been to India 5 times, given probably 10 workshops in India. And what I'm going to be talking about with you today is couple sex therapy for low desire and desire discrepancy problems. And I want to be clear that my research and my work has been and borrowed from people from Canada, from the US, from UK, rather than Indian data. But I think much of this is very applicable. And I know that the Indian sex education, counseling, and therapy field has really grown over the time. Now, one of the things you will have available if you want from your website, from your organization, is a 58-page handout, which is mostly material about desire and mostly material for couples, and as well as individuals about different sexual problems. None of that material is copyrighted, so you can modify it in any way you want and use it in any way you want. And that's what, and I really do mean that. What the material we'll be talking about now is about couple sexuality. If you want to put up the first slide, I think it tells you a little bit about, why don't you put it on the second slide now? That's the sexuality workshop. And the second, this is a little bio about me and my background. And then the most important slide is the third slide, which is the core concepts. So if you do get the 58-page handout, on page 1, there is a 25-item true-false test for the lay public, and it's all about old and new sex myths. On page 2, and there's a handout about what I learned when I trained to be a psychologist and a couple therapist, and they are all about professional myths. And I think knowledge is power, and you want to have good knowledge about the role and meaning of sexuality in your life and in your client's life. When I trained in this area, and I got my PhD way back in 1969, my understanding was that the key for sex was arousal, intercourse, and orgasm. If that is functional, everything else is fine. And that's what Masters and Johnson said, who are the founders of the sex field. And I have great respect for them, but they were wrong. It's important to note they were wrong. The core issue sexually is sexual desire. So, and this is on your core concepts, it's page 3 of your handout. And when people often say, well, how can I talk about sexual issues with individuals or couples? My strong suggestion, and again, I'm not trying to be dogmatic or say there's one right way to do it, but my very strong suggestion is that if at all possible, do the first meeting as a couple. And that one of the first questions to ask is, when in your relationship did desire, pleasure, eroticism, and satisfaction function the best for you? And then follow that up with the question of, now in your sexual relationship, how is desire, pleasure, eroticism, and satisfaction working? You're giving them a new vocabulary where they're using similar language with each other, where it's not split by gender. And that's one of the core problems with sexual desire. The way that couples learn to be sexual is quite different. Traditionally, males learn to be sexual autonomously. What you mean by that is he is able to feel desire driven by a spontaneous erection. He's able to go to intercourse and orgasm and need nothing from his partner. For most women, sexuality is an intimate, interactive experience. It is not an autonomous experience. And one of the major things that they need to help them do as adult sexual people is to understand there are many more similarities and differences sexually between women and men. And couples who focus on that in that sense of a sexual equity model, rather than traditional double standard, do so much better sexually. And again, the core issue is, although I love intercourse, I love orgasm, is not intercourse and orgasm. It is, again, desire, most important, pleasure second, eroticism, and satisfaction. And the challenge for couples, whether they're married or partnered, is how you integrate 3 very different concepts. Intimacy, which is about how close and warm and trusting you feel. This concept of non-demand pleasuring, enjoying all kinds of touching, not just intercourse touching. And then erotic scenarios and techniques. And that's equally important for men and for women, is that integration. The traditional split and the traditional cause of desire problems is this emphasis that women emphasize intimacy, emphasize the security of the relationship, emphasize warmth and loving communication, and men often emphasize intercourse frequency and eroticism. The truth is, you need to have a similar language and a comprehensive assessment. 1 out of 3 adult women complain of secondary desire problems. What that means is they once felt desire, but they've lost it. But one of the things that most people, including sex people, sex clinicians and professionals, don't understand is that when couples stop being sexual, especially after age 50, in 85 to 90% of the cases, it is the man's decision. And he makes that decision not because he wants to stop sex, but because he's lost his comfort and confidence with erections and intercourse. And so he says to himself, I don't want to start something I can't finish. I feel really uncomfortable. I feel like a failure, so I avoid. It's a terrible decision for the man and the woman. And the third item is personal responsibility. You're responsible for your own desire and your own orgasm. Your partner does not give it to you. And it is not the male's role to give the woman desire and orgasm. It is his role to be an involved partner. She needs to find her sexual voice, and especially including her erotic voice, because ultimately sex is a team sport. You want to be intimate and erotic allies. And so many, if I sat in my office and heard this 1,000 times, where the man says to the woman, or the woman says to the man, I love my husband, but I no longer am attracted to him. She has de-eroticized him. He has de-eroticized her. They feel de-eroticized as a couple. It's also a really important item about the positive functions of couple sexuality. Sometimes the major function is sex as a shared pleasure. It allows you to feel desired and desirable. It reinforces intimacy. And we underestimate this, but sex is a tension reducer. So it's got multiple functions and multiple meanings. That's an important thing to understand in terms of desire. The problem, if there's one thing you take from this workshop, this is what I would like you to take. I hope you take a lot, but this is what I'd like you to take. And that is the paradoxical role of sex in people's lives and relationships. When it's healthy, it plays that 15 to 20% role. It allows you to feel desire and desirable, and it energizes your bond. The paradox is this: when sex is avoided, when it's dysfunctional, when it's a source of conflict, it plays an enormously powerful negative role. And when couples get divorced, especially early in the marriage, the most common time they get divorced is the first 5 years, at least in the West, and the issue is sex. They stop being sexual. They're dealing with infertility problems. They're dealing with conflicts about affairs. It happens early in the marriage. Last but not least, in terms of core concepts, is that what I encourage people to do is to think about whether they have a similar goal, and that is to have a satisfying, secure, and secure is different than stable. Secure means you value your partner and you value your relationship. Stable means you're going to stay together, whether for religious reasons or for the sake of the children, but it's not a genuine relationship. So satisfying and secure, and the role of sex is that 15 to 20% role of energizing your bond and reinforcing feelings of desire and desirability. That's the major core concept. Now, if you switch now, we switch slides to slide number 2. Can we switch to slide 2? That's the one about the overview of couple sex therapy. Is that possible to switch? Okay, if you can't switch, the world won't come to an end. Again, if you get your slides, oh, there it is, in the overview. Now, I'm not saying this works for all people and all couples. But I am saying it is an interesting model that I'd really suggest to you. And that is a 4-session assessment model. If at all possible, because usually people come alone, the man comes alone, the woman comes alone, and they blame the partner. If at all possible, see the couple as a couple for the first session, because it reinforces the message. And the message is that at its core, sex is an intimacy and sexuality is a couple process. It is not primarily an individual process. And that it's a powerful message that says the desire problem is a joint enemy. It's a joint problem. Stop being in a power struggle and arguing about whose fault it was you're a non-sexual couple. Let me use a couple of definitions here based again on the Western research. The operational definition of a non-sexual marriage is being sexual less than 10 times a year, less than once a month. A low-sex marriage is being sexual between 11 and 23 times a year. And the average frequency of intercourse sex is between 3 times a month and 12 times a month. For most couples who've been together a year or longer, it's about 58 to 62 times a year. So again, having positive, realistic expectation rather than overpromising or quack performance demands is a really helpful concept. The second thing that I would like to encourage you to do for most couples is to have an individual psychological relational sexual history. That if you do the history with the spouse in the room, you're not going to get the genuine narrative. You're going to get a socially desirable statement, but not the genuine story of that person. You know, I've done over 4,000 of these. Of the married couples with sex problems, 80 to 85% have sensitive secret material that the spouse doesn't know. It won't come out if the spouse is in the room, but it is important to understanding the problem. It really is a crucial thing. Let me make one other point. And by the way, the sex histories is on page 5 or 6 of the handouts. And they're not, you can change it in any way you want. Always ask open-ended questions. Don't ask yes/no questions. So if you ask the question, for example, have you ever had an affair? Nobody in India has ever had an affair. If you ask the question in an open-ended way that encourages them to tell their story, that the majority of married people have thoughts, feelings, fantasies, experiences of being sexual outside their marriage. Tell me about your experiences. It makes it much easier for them to tell their genuine story with its strengths and with its vulnerabilities. In this model, the couple feedback session, which is scheduled as a 90-minute session, the others are scheduled as 50-minute sessions, but the couple feedback session is a 90-minute session, is the core intervention. And what we do in that session is that both people are there, but you turn your chair so you're looking at the partner who's most reluctant to change. So that's the way to start. And start off by talking about their strengths psychologically, relationally, and sexually, but then talk about their vulnerabilities. And to make sure you've got a new and genuine narrative about who your client is. And it's often new information for the spouse. And then you make sure that it's the right narrative, and then you switch to the spouse and you go through the same process. So you talk about their strengths and vulnerabilities as people first, and then you talk about their strengths and vulnerabilities as a couple. So that's the first thing we do in the feedback session. And then the second thing we do in the feedback session is we talk to them about a therapeutic contract to address the couple desire problem, with the idea that desire is the joint enemy. It's an intimate sexual team experience. And usually the most common therapy contract is a 6-month good faith effort to try to create a new couple sexual style and a healthier relationship. That's the joint goal. And I will often say to them, in my clinical experience, over 75% of people are able to reach that goal and care about it. And then the third part of the feedback session is to assign a psychosexual skill exercise to be done at home. There's 2 things that make sex therapy different than other kinds of psychotherapy or couple therapy. The one is the importance of psychosexual skill exercises. And again, if you get your handout, the psychosexual skill exercises are from pages, I think it's 11 to 18. You'll be able to see them easily enough. It's the importance of reading about the issue, talking about it both in therapy and at home, but the most important thing is to begin with the desire exercises. And although sensate focus is an extremely good technique, an extremely good strategy, when it comes to desire problems, my suggestion to you is to deal with desire problems directly. And the exercises are comfort is the first exercise, ways of increasing attraction is the second exercise, developing a trust position where you feel safe with your partner is the third exercise, and the fourth and most important exercise is creating your new sexual scenario. And each of you get a chance to do that, both the man and the woman. I've done this again with many, many people. I've never worked with anybody who has the exact same scenario. And that reinforces something that's crucial in understanding sex problems. And that is that you need to have your authentic sexual voice in order to really be part of an intimate sexual team. It's a 1-2 combination. And you don't give up your autonomy in order to be a team. It is a balance of autonomy and being an intimate team. But by the way, that's the second thing, although we won't get a chance to focus on it in this webinar, that sex therapy brings to this field. And that is that for most couples, the best friend relational style and how you deal with conflicts and differences, the best friend relational style is the right choice. It is not the right choice sexually. One of the most helpful concepts is that your couple sexual style is usually different than your relational style. What you mean by your couple sexual style is this idea of autonomy and intimacy is one balance, and then intimacy and eroticism as a second balance. So that when you're talking about couple sexuality, you're really talking about this concept of having a balance that fits for both the man, the woman, and the couple. And then by the way, the psychosexual skill exercises are always done in the privacy of their home. There is no touching nudity or sexuality in your clinical office, but there is touching, intimacy, sexuality, practicing the exercise in the privacy of their home. We usually start as a couple. Doesn't mean you cannot ever see one partner alone. In fact, I encourage you sometimes to do that, but that the prime modality therapeutically is couple work. And that's also true whether you're talking about a medical problem or not a medical problem. For so many people, when they talk about medical problems, whether it's diabetes, whether it's surgery, whether it's cancer, whatever, the idea is you see the person alone. But what I would like to suggest to you, and you usually use medication as a major modality, and the medication is a standalone intervention. What I'm going to suggest to you is not the traditional biomedical model. I'm going to suggest to you the biopsychosocial model. When I give these speeches in the West, I call it the psychobiosocial model, but I'm going to be respectful of the medicine orientation. Let's call it biopsychosocial. And that is, you look at medical factors not as a loss, but as a challenge. You look at medical interventions, whether oral medications, shots, whatever, as not a standalone intervention, but it needs to be integrated into the couple's sexual style of intimacy, pleasuring, and eroticism. So it's a balanced integration approach, not a standalone approach. And that you assign different exercises each week. So you're trying to build a strong, resilient, new couple sexual style that integrates intimacy, pleasuring, and eroticism. Typically, couple sex therapy lasts 10 to 25 sessions, which translates to 3 months to a year. There are people who you have a one-shot consultation with. There are people you're going to see for years. But generally, it is a focused therapy and a time-focused therapy. And when you're doing good work as a couple, you've got 5 clients sitting in front of you. The woman is one client, the man is a second client, their general relationship is a third client, their sexual relationship is the fourth client, and the hardest client is their history as a sexual couple. That's where they often have struggles and fights and blaming and counter-blaming. One of the things I always say to my couples is you want to stay away from power struggles. With power struggles, nobody wins. It's all about who's the bad person. What you want in healthy relationships is a positive influence process where you join as intimate neurotic allies to be a broad-based sexual team. Now, one of the things that I do, and I don't know if you do this at all in your culture, but I am a strong believer in relapse prevention. That in fact, relapse prevention is a core issue. And the people who are most demoralized who sit in my clinical offices are people who changed, whether because of a medical or mental health intervention, and now have relapsed again. They're demoralized and they say, is it my fault, my spouse's fault? Do we have a fatally flawed marriage? When I say to them, is this therapist or this physician who you liked and respected, did they give you a relapse prevention program? And invariably they say no, and I say blame the clinician. Relapse prevention is an integral part of good work with individuals, couples, and sexuality. So what I do is I see them I try to see them at 6-month intervals for 2 years. It's a message that said, I care about you and I care about you continuing your growth as a couple. So that's the overview, that's the approach, that desire is the core issue, and that rather than focusing first on a dysfunction, non-orgasmic response, premature ejaculation, erection, focus first on rebuilding desire. And that the core element in desire is a pleasure rather than a performance orientation. And once you develop that and you're dealing with the anti-avoidance, that's when you tackle as a couple sexual function issues. It's a different approach, I know, but in many ways, it's a much healthier approach in changing people and in preventing relapse. Now, if we could switch to the next slide, which is the guidelines for revitalizing and maintaining sexual desire. There's actually 2 parts to this slide. And again, it's not copyrighted. You can change it in any way you would like. But here's the core issue, that when we talk about what is sexual desire, is it the fact that you're a wonderful lover, you're very sure of yourself, you perform for your partner? No. The core of sexual desire is positive anticipation. You want to look forward to being sexual in the same way you look forward to going to your favorite restaurant or your favorite museum. It's something to look forward to. It's something to share. That sex is a good thing in life. It's integral to who you are as a person, and you want it to play that 15 to 20% role. Secondly, in terms of what causes desire, is that you feel deserving. You feel that you deserve to give and receive pleasure-oriented touching. It is a positive part of your life, and it's not contingent. So even if you're overweight, even if it's a stressful time in your marriage, even if you lost your job, even if your child just was dismissed from high school or whatever, you still deserve sexual pleasure. So it's anticipation, deserving. The third element in terms of desire is the sense of freedom and choice. And that's a really important concept. That is, if you do not have the power to say no to sex, you do not have the freedom to say yes to sex. So you want to be able to feel that you can veto a scenario or technique, and your partner will honor your veto, but you won't avoid. You will get together in some way to share touching, sexuality, and pleasure. And the more And then the last thing is you want to have sexual experiences that have some variety and some flexibility to it. One of the major things that inhibits sexual desire, probably the major thing that inhibits it, is pressure, performance pressure, anticipatory or performance anxiety. But the other one is you have a very narrow repertoire. It's intercourse or nothing. And so you get into that power struggle. That what you want is so even if you have a sexual relationship where every Saturday night after watching a movie you have sex and the sex is functional, it does not enhance desire. Routine, totally predictable mechanical sex subverts desire. The thing in terms of gender vulnerabilities, and I like that word rather than weaknesses, the major gender vulnerability for men is this performance pressure of intercourse or nothing. What happens with most men, not all men for sure, but most men, is they learn autonomous spontaneous erections in their teenage years, their 20s, and their early 30s. For the great majority of men, sometime between 35 and 45, they have a sensitizing experience. And what you mean by that is they do not have an erection sufficient for intercourse. For most men, once you have a sensitizing experience, you do not return to autonomous sex. The good news is you can be a better, more involved, more aware lover and enjoy sex more for yourself and your partner. The bad news is so many men get into the negative cycle. Anticipatory anxiety, performance anxiety, and the major reason, this is an important concept, especially for the medical people, that Viagra or Viagra type medications fail is that as soon as he gets an erection, he rushes to intercourse because he's afraid that he'll lose his erection. And we'll talk about this in just a little bit about the levels of touch and dimensions of touch. But that one of the most important concepts is do not transition to intercourse when you get an erection. Transition to intercourse when you're feeling subjectively aroused and have a firm erection. When you transition to intercourse early, you're rushing intercourse, you often wind up losing your erection and feeling like a Viagra failure. Viagra has probably caused more non-sexual marriages than anything else in history. Not because it's not a good drug, it is a good drug, but because you're asking the drug to do it all. You can't ask the drug to do it all. It's got to be integrated in their couple sexual style. And this is a note I'd have you take. And that is the individual sexual pass-fail test. Erection and intercourse for the man, orgasm for the woman, inhibit sexual desire. That a much better sexual model is called the good enough sex model. The good enough sex model is a couple concept based on sharing pleasure and based on positive, realistic expectations. That's the good enough sex model. It's a couple model based on pleasure. And based on that, if you look at couples who are in their 50s, 60s, 70s, 80s, that 85% of their encounters will flow from comfort to pleasure to arousal to erotic feelings to erotic flow to intercourse and orgasm. But when it doesn't flow, rather than apologizing, there's nothing more anti-erotic than being self-conscious or apologizing or panicking. You turn to your partner and say, this isn't going to be an intercourse night. Let's have a sensual date or let's have an erotic date. Let's have a good time sexually. It isn't intercourse or nothing. And I know it sounds easy on paper and pencil or easy in a webinar. It's very challenging for real Indian couples in your office, but it is the key to maintaining sexual desire. What I say to my men is you can be a traditional man, and traditional men stop being sexual somewhere between 40 and 60. Or you can be a wise man, and you can be sexual in your 60s, 70s, and 80s. That rather than saying real men it's intercourse or nothing. Real men value and embrace variable flexible sex. They embrace good enough sex. And women generally very much embrace good enough sex. Now, one other point that I'd like to highlight in this, and again, I hope you take these home and look at them, is that most couples do not have desire problems. Most couples begin as a limerence phase couple. And limerence means romantic love, passionate sex idealization. I love the limerence phase, but the limerence phase is a very fragile phase and is very time limited. It's usually 6 months to 2 years. So many people sit in my office and say that our best sex was the first 6 months. To me, what happened to them is they never developed a couple sexual style with strong, resilient desire. And that's especially important in females, but it's also important in men. Now, if you switch to the second page, so the next slide, the second page of guidelines for revitalizing. We're going to talk about this thing about years of touching in just a second. But the thing that I want to focus on is the idea that desire is fed by a number of bridges. And one of the more important exercises have an exercise where she develops her bridges to desire, what she anticipates. He develops his bridges, and they develop our bridges. And that they're open to touching, not just for intercourse, but touching both inside and outside the bedroom. And they really do embrace individually as a couple the good enough sex model. So when they talk about sexuality, it isn't just intercourse and intercourse frequency, although that is tradition in the culture, in the US culture, the Indian culture, the Canadian culture, the UK culture. And I love intercourse. I'm totally in favor of intercourse. But again, if you look at the data, the average frequency of intercourse is a little bit more than once a week. Couples that have embrace a broader, more variable, flexible approach to pleasure-oriented touching do much, much better than the couples who define intercourse narrowly as this idea of intercourse and nothing. And the notion also, I think, is important, and that is the more you avoid, actually, if you go down a little bit more on that slide, or maybe you can't, if you can, okay, actually, you're exactly where I want you to be. You want to have both personal and external turn-ons. You also want to understand the positive function of touching, that it's more than intercourse. But here's the thing I really want you to get from this. And that is the best sex, and this is item here, it says realistic mutual expectation. The best sex is mutual synchronous sex. What you mean by that is both people in the relationship feel desire, pleasure, eroticism, and satisfaction. That's the best sex, far and away. But it's really important to understand that among happily married, sexually functional folks in the West, less than 50% of their sexual opportunities are mutual and synchronous. Most couple sex is asynchronous. What that means is it's positive, but it's better for one partner than the other. And what usually happens, and again, I always try to use the words things like usually, not everybody, every time. But what usually happens is that for couples under 40, asynchronous sex tends to be better for the man than the woman. It's easier for him to get aroused, easier to be orgasmic. But if you look at folks over 65 who stay sexual, the asynchronous is a gender challenge and a gender change, and that is the asynchronous sex is better for the woman than the man. So couples, the good news about sex and aging, the science is absolutely clear on this, that you can be sexual in your 60s, 70s, and 80s. The most important good news is that couples who stay sexual are more satisfied with their sexuality with aging, menopause and after menopause, than are couples in their 30s and 40s. And it's partly because sex and aging is more genuine and more human. You need each other in a way that you didn't in your 20s and 30s. It's a really interesting part of sexuality. But here's the part that I, again, want you to, as a take-home message. And that is, among these happily married, sexually functional Western folks, 5 to 15% of their sexual encounters are dissatisfying or dysfunctional. In other words, it's normal to have lousy sex or mediocre sex. That really is good for your couples to know, because there's a tendency that says if we didn't, it wasn't totally mutual, or in the worst of cases where they have unrealistic performance demands of simultaneous orgasm, they feel badly, they apologize for themselves. Again, the negative cycle, anticipatory anxiety, tense, performance-oriented sex, embarrassment, frustration, and avoidance. You really want to confront that. And that's what happens. The less sex you have, the more self-conscious you get. And that really interferes with this desire, pleasure, eroticism, satisfaction cycle. Now, according to my watch, I have 15 more minutes, that I'm more or less on time, I hope, somewhat more. So what I'd like you to do is to go to the last slide, if we could. The last slide says the crucial couple sexual dialogue. So that's the last slide. All right. Now, let's talk a little bit about, go back to the first part of the last slide. So it's what's on there now is the second part. So you want to go back to the first part about the crucial couple sexual dialogue. Okay. And if we don't get there, it's okay. No, one more. You want one more after that? One more after that? Nope. Doesn't look like we got it. It's okay. Oh, there it is. Okay. The crucial couple sexual dialogue, 5 dimensions of touch. Again, psychosexual skill exercise in the privacy of their home is one of the best things about sex therapy. If you use no other exercise, this is the most important exercise because it does 2 things in this exercise. And the way to think about psychosexual skill exercises is you read it first, individually as a couple. You discuss it at home and in therapy. But the most important thing is you implement it. You try the exercise not once, but 2 or 3 times. And the focus of this exercise is twofold. The one is to redefine sex, to confront the myth that sex equals intercourse. That what you want to do is you want to say there are 5 gears or 5 levels or dimensions of touching. Sensual, affectionate touch is 1. It's like a stick shift car. Sensual touch, affectionate touch is 1, gear 1. Sensual touch is gear 2. Gear 3 is playful touch. Gear 4 is erotic non-intercourse touch. And gear 5 is intercourse. So you wanted to, affection, I am a big fan of affection, but affection is not sexual. But it anchors you and attaches you. But sensual touch, the 2nd level, playful touch, the 3rd level, erotic touch, the 4th level, and intercourse that touch the 5th level, all of those are sexual. You expand what you mean by sex. It's not just intercourse or nothing. And the second part of the exercise is to emphasize that subjective arousal is more important than erection and vaginal lubrication. It's a very hard sell for both men and women, but especially for men. But men who understand and adopt that, more than the pro-erection medications they're taking, that is what builds comfort and confidence with erections. That and a good enough sex model. So sensual touch means non-genital touching, things like cuddling on the couch, doing a body massage, but not generally, doing a foot massage or head massage. And that subjective arousal in terms of sensual touch is between 2 and 3. So affection anchors you at 1, sensual touch 2 or 3. The third level or third gear is playful touch. And playful touch means intermixing genital and non-genital pleasure. And subjective arousal is 4 or 5. Examples of playful touch is taking a shower or bath together, dancing in a romantic or erotic way, doing a whole body massage, including genitals, playing a silly game like Twister or strip poker or something like that. The point that I think is important is that often it'll evolve into intercourse, but that playful touch has value in and of itself, and it is sexual. Sensual touch has value in and of itself, and it also is sexual. And then the fourth gear is the most controversial gear, and that is erotic non-intercourse touch. And that, in terms of subjective arousal, is between 6 and 10, 10 being orgasm. And the most common forms of erotic touch are manual stimulation, oral stimulation, rubbing stimulation, and vibrator stimulation. It can be mutual or it can be one way. And again, they all have value. And much of the time it'll revolve into intercourse, but it doesn't have to. Being orgasmic on non-intercourse touch is not only valid, embrace it. It is healthy for you. And not just as a backup, but as a way of sharing pleasure and eroticism. Couples, for example, there's good science now that married couples who masturbate occasionally by themselves is good for their marital relationship. Couples who engage in sensual or playful touch, it's good. Couples who do erotic touch, whether mutual or one way, is good. As long as it's not at the expense of the partner or the expense of the relationship, it's not a performance, it's not a transaction, it's genuinely sharing pleasure and eroticism. And then that brings us to the fifth gear, which is intercourse. And the key issue in understanding intercourse sex is that intercourse sex is part of the pleasuring and eroticism process, not a pass-fail test apart from the eroticism and intercourse process. Again, people will say we were sexual if we had intercourse, we failed if we didn't have intercourse. That is poisonous for sexual desire. Embrace a range of experience, including dysfunctional sex. You know, my favorite story of all my clinical stories over the years is I went to a workshop with Bill Masters of Masters and Johnson. And the second day of the workshop, I finally got up the courage to ask him a question. I was about 34 at the time, a long time ago. I showed him an article about erections and treatment. And I said, what do you think of it? And he looked at the article and said, that's bad science. And he actually threw it in the waste paper basket. And then he looked right at me and he said, do you know how you can be sure a man is cured of erectile dysfunction? It's like God speaking to this young psychologist. And he said, whether it happens once a month or once a year, when you don't have an erection sufficient for intercourse and you don't panic and you don't apologize, you know you're cured. It is normal. That's part of good enough sex. It is normal to embrace variable, flexible couple sexuality. That's a normal thing. So it really is important to have them talk about this in therapy and outside, but the most important is actually experiment with sensual scenarios, actually experiment with erotic non-intercourse scenarios, and make it clear that they can veto anything that they don't want, but they can't avoid. The way to understand this approach to touching and desire is it's a responsive sexual desire approach, not a performance approach. That responsive sexual desire was developed for women over 50, but it's applicable to men and women over 50. And the idea is you begin a sexual encounter, you can begin it at zero, at neutral. And as you touch and are touched, You're aware of your feelings and your partner's feelings. That's when you feel subjective arousal 3 or 4. That's when you feel desire. You don't have to feel an automatic erection or erotic charge. You can, desire is responsive to the physical and psychological experiences. One of the most valuable of all the exercises, and I'm going to wrap this up in 2 minutes. One of the most valuable of all the exercises is when you have an experience with a couple where one partner, usually the man, was orgasmic and the woman was not orgasmic, but the woman feels more satisfied with the sexual encounter than the man does. It reinforces that satisfaction is more important, is more than orgasm. Again, I'm a great fan of orgasm for men and women. But the idea of orgasm as a performance hurts desire. Orgasm as part of the pleasuring eroticism process really feeds desire. Last but not least, couples have to figure out what is the right sexual style for them. They usually say, well, we're best friends, so that must be the right sexual style. The best friend sexual style is not the right style for most couples. Not. Because there's so much closeness that they de-eroticize each other. And there's so much emphasis on mutuality that you can't initiate an asynchronous sexual encounter. Asynchronous sex is good for people. And understanding the different roles and meanings of sex is good for people. That the people who have embraced broader based sexuality do so much better. So you can be an intimate sexual team as a complementary couple sexual style. That again is in your handouts. It's now 10 after 12. I know at least my time, and I was supposed to end my time at 12. Maybe this is a good time for questions, comments, to clarify things we went over way too fast about.
Thank you very much, Dr. McCarthy, for this wonderful explanation on couples therapy. You have explained the core concepts. You explained all the exercises, all the gears beautifully. I know this is too short, but we need still more understanding and more in-depth study about everything. There have been many questions, but one important question is how to tackle mismatched sexual desires post-marriage. Before marriage, it is something different. Post-marriage, it's something different.
It's so easy to say what not to do.
Yes.
What not to do is to be in a power struggle where the person with the higher desire puts down or pressures or coerces the person with the lower desire. That is a poison. It's like taking a cancer pill or a poison pill. It really destroys intimacy and desire. So what needs to happen is that they need to say to each other that we were a limerence couple, or a romantic couple where they had intercourse or not before they married. And we really did feel that positive anticipation, sense of pleasure, whether they were orgasmic or not. But now we're a married couple. And as a married couple, the challenge for us as a couple is to integrate intimacy, pleasuring, and eroticism into that same relationship. And that one of the best ways of doing that is reinforcing each person's sexual voice. So for instance, the man's sexual voice is usually still an autonomous functioner, but he doesn't have to perform for the woman. He doesn't have to have great ejaculatory control for the woman. That he has to be comfortable and share pleasure with her. And if they're going to learn better ejaculatory control, and that what that means is not that she has an orgasm during intercourse. Remember, 1 out of 3 women is never or almost never orgasmic during intercourse. It is that intercourse is a more pleasure-oriented activity. The bigger issue, though, typically is for the woman, where the woman, after the limerence phase, they fall into a routine, and it's usually the man's routine. And that is, he initiates sex. He does foreplay on her to get her ready for intercourse. And as soon as he feels she's ready, they go to intercourse. That way really de-eroticizes her and shuts down her sexual desire and voice. What works so much better is if they're equitable friends and where she finds her sexual voice, including her erotic voice. The idea that eroticism and intercourse belongs to him and intimacy and stability belongs to her is crazy making. It is bad for desire. It takes away from the complexity and reality of men, women, and couple sexuality.
There's one more question. Many husbands come to for taking medications for erectile dysfunction,
Right.
and they have hidden this from their partners, and they say that we don't want our partners to know about that they are taking medications for their problem. And there are other couples, other men who feel that they desire to have sex more with the other women other than their partners or the life partners of their wife. What
Right.
do we how
Okay,
do
so
we
let's take one at a time.
Yeah.
One of the things that I would suggest, especially for the physicians in the audience, is when you're seeing a man coming in for erectile dysfunction, see his partner at the same time. That together they need to build comfort and confidence with erections, and it isn't erections as a pass-fail individual test. But the other is that when sex, in terms of good enough sex, when it doesn't flow to intercourse, that they're comfortable with sensual and erotic backups, whether that's synchronous or asynchronous. So again, desire and erections are a couple issue. What happens with so many males, but it also happens with females too. This idea that men and women are different species is not true scientifically, not with adults. Is that that they never really find a couple sexual style that blends intimacy and eroticism. So many people, again, will say, I love my spouse, but I'm no longer sexually attracted to them. One of the best things, again, is that attraction exercise and the desire exercises. You can increase attraction, but the biggest way you do that is you confront and get rid of the poisons that subvert desire. Now, for most people, they're going to have a traditional agreement about monogamy and sharing sexuality with their spouse. It's also important to understand, as in the West, there's going to be 8 to 15% of couples who have a consensual non-monogamy agreement. But it's even more important that you see them as a couple, because it's very hard to get a consensual non-monogamy agreement that really works for both people in the relationship. The majority of people, though, are going to have a traditional agreement. That one of the most important things in the traditional agreement is how they incorporate eroticism into their couple sexual style. This whole thing about de-eroticizing the partner, I know I've said it at least 3 times, but that is one of the major causes of desire problems. And to understand that what works in fantasy is different than what works in reality. So for example, one of the best suggestions for both men and women is to engage in multiple stimulation, both before and during intercourse. And the most common forms of multiple stimulation, and only works, by the way, if your subjective arousal is at least a 6 or a 7. If your subjective arousal is 2 or 3, multiple stimulation will make you feel awkward. But if you're into it, it'll be helpful in a turn on. The most common form of multiple stimulation for women receiving is receiving manual clitoral stimulation, receiving buttock or anal stimulation, and receiving breast stimulation. For men, the most common form of receiving is receiving testicle stimulation, especially during intercourse, buttock stimulation, and kissing stimulation. But for both men and women, this is an important controversial point. The most common form of multiple stimulation is using erotic fantasies. And you never have a fantasy about having sex with your spouse in your bedroom in a missionary position. By its nature, erotic fantasies are not socially desirable, but erotic fantasies can serve as a bridge to desire and a bridge to arousal and orgasm. And what works in fantasy is different than works in reality. So erotic fantasy is not having an affair. It isn't the same as having an affair. It is a normal, healthy way to experience subjective arousal. Is that too complicated or does that make some sense?
Yes, it makes sense. Thank you very much, Dr. Barry. May I now request Dr. Bala Subramaniam to be in short and give us his concept about couple sex therapy very shortly in a minute or so. Over to you, Dr.
Thank you, Dr. Jubani. See, Indian settings, especially, it varies from north and south also. South, the culture is different from the north. And many times it is seen in married couples. Whenever there is a disharmony, the wife takes permission of the, with or without permission, goes to her mother's place for a relaxation. And she comes back, or sometimes the husband has to go and fetch her, inducing confidence into them. So the mother's place, mother of role is very crucial in South. So she advises, mother advises. Many of the counseling is done by the mother to her daughter, and she comes back and lives happily with the husband. And the quacks are rampant in South, and many times the husband goes and seeks treatment from the quacks. So, as told by our national president, Dr. Jayalal, IMA should come out with a fellowship course and develop qualified counselors or doctors to tackle this problem. And I hope Dr. Narayan Reddy's curriculum and the course. And it is very nice to hear Dr. McCarthy. We had a wonderful workshop at Chennai. About 40 doctors who had undergone our fellowship course. They attended this one-day workshop and they benefited a lot. And I still remember his 5 years of sex therapy even now. And we thank Dr. McCarthy for delivering yet another useful lecture.
Thank you, Dr. Bala. Dr. Barry has given us a 60-page handouts, which I will circulate to all in the groups and also to CSCPI and SASM and ISSM groups, to all of us. Now let's have the final word, in short, from our mentor, Chairman Emeritus Dr. Narayan Reddy, to sum up whatever Dr. McCarthy said and what are his concepts in 2 minutes. Over to you, Dr. Narayan Reddy, please.
Jumani, as you suggested, I'll be very brief. There's nothing much I can add to what Professor McCarthy has already spoken. But I remember very much Masterson Johnson's statement that there's nothing called an uninvolved partner where a sexual problem exists. Taking from that, again, if I remember correct, Keith Horton, he said, when there is a problem, you must know whom to treat or manage. It is the husband, the wife, or the relationship. That's what exactly Dr. Professor Barry McCarthy is trying to tell. The couple should be involved rather than an individual. Unfortunately, we, the medical fraternity people, we are making a mistake. We are looking at only the symptom and not in a holistic perspective, looking at the couple as such rather than looking at the penis alone. That's the mistake we are making. Even the question came which about erectile dysfunction just before. We are looking only at the penis, which is not correct. And Professor McCarthy very clearly used to tell right from the time I first heard him, number of years ago, along with Dr. Vassa. He keeps telling us, reminding us, a couple need to be handled. And if you read all his books, it is very clearly talks about communication skills between the couple and how to help themselves. So with that, I'll conclude my remarks.
Thank you very much, Dr. Reddy, for
Thank you.
those wonderful remarks. And Dr. McCarthy, you were simply awesome. Many useful things which you have taught us today will make a great difference in our practice when we call couples to counsel them. I also thank Anita Sham for being the bridge between Barry McCarthy and us, and also helping us for the slides. and Dr. Bala for being here, Dr. Jailal for gracing our occasion, gracing this occasion as being a chief guest and giving us a good guidance and understanding our issues and taking our issues further with the Medical Council of India. I also thank Dr. Dilip Maheshkar for being here and sharing his views on what he feels about couple sex therapy. I thank Zydus, I thank Aishwarya, I thank Somalia and everybody involved here from the bottom of my heart for making this prestigious, most meaningful, most useful webinar with Dr. McCarthy. It was a wonderful evening here, and a lot of learning. Thank you very much. Thank you, all of you. Thank you very much. We'll be seeing again each other on the 3rd of February with Dr. T.S.S. Rao and Dr. Raj Brahmbhatt, who's going to speak about is sex still a taboo? Thank you very much. Thank you all.
Thank you so much, Deepak sir, for the wonderful moderation. Thank you to all our faculty for teaching us so much. We look forward to learn from you again. Thank you very much.
Thank you, Barry. Thank you, Dr. Reddy. Thank you, Bala. Thank you, Anita. Thank you.
Thank you.
Good night.
Good night.